important part of managing MDRs is to know which patients are at risk of MDRs. And by our clinical practice, I did my MBBS 25 years ago, and I know usually risk stratification always meant clinical risk stratification. Looking at patients' oxygen saturation, fluid requirements, blood pressure, vitals, everything. But that's clinical stratification. But we did not pay much attention. Is the patient at risk of getting MDRs? If I have a young 25-year-old having a road traffic accident with a head injury in ICU, why the patient should be on meropenem? Simply because he's in ICU? No, right? There has to be some justification for giving a broader antibiotic. Is the patient at risk simply because he's very sick, therefore we have to give higher antibiotic? That's the clinical risk. But for giving or justifying a higher antibiotic, we need to know the risk stratification for MDRs. And basically, there are three big risk factors. Prior history of antibiotic intake in the last 90 days, prior hospital exposure or healthcare exposure, and comorbidities like diabetes, renal failure, or immunocompromised situation. Okay, as you will see, what are the risk factors for ESBLs? See, all the p-values are so significant. Treatment with second or third generation cephalosporins, hospitalization in the last 3 months, treatment with quinolones, antibiotic treatment in the last 3 months, age more than 60, diabetes. So you can see three basic factors: prior exposure to healthcare in the last 90 days, prior exposure to broad spectrum antibiotics, and comorbidities. These three are your biggest risk factors to see whether a particular patient needs an ampicillin, needs a cephalosporin, or needs a carbapenem. Okay, so this is for ESBL. Similarly, you can see ESBL-producing Enterobacteriaceae within first 48 hours of hospital. Okay, previous therapy with beta-lactams or fluoroquinolones, history of catheterization, that means some healthcare exposure, some instrumentation, old age, recent hospitalization, admission from another healthcare facility. So again, you will see these are repeated risk factors. You will see in ESBL, MRSA, Pseudomonas everywhere. Okay, look at Pseudomonas. Any patient who has had some invasive procedure, mechanical ventilation, or any surgery, okay, urinary catheterization, they are at risk of Pseudomonas. Remember, Pseudomonas is a nosocomial pathogen. It's a non-fermenter. It's very rare to get a Pseudomonas from the community. Usually these patients have had history of invasive procedures or too much exposure to broad spectrum antibiotics, mainly fluoroquinolones, carbapenems. These two are very big risk factors for getting a resistant Pseudomonas infection. Prior history of patient getting fluoroquinolones and carbapenems. Apart from that, any surgery, mechanical ventilation, urinary catheterization. See this, for CRE, carbapenem resistant Klebsiella. Sorry. What are the risk factors? Again, mechanical ventilation, invasive procedures, number of days of carbapenem use, antibiotics during hospitalization prior to infection. So again, I'm coming to the same thing, that the major reasons are these exposures for a patient to acquire such resistant infections. Again, KPC is the same I have covered. This is a very good summary from Bassetti paper. This came in 2017. Risk for MDRs. See baseline characteristics: higher age, sicker patient, diabetes, recurrent obstructive UTI, steroids, immunosuppression, recent surgery, neutropenia. Epidemiological background: if a patient is having a history of prolonged hospitalization, recent antibiotic use in the last 3 months, prior colonization, and any indwelling devices. Okay, so always look for these risk factors. Now you will say these are so many risk factors. How do I quantify them? This is a very good, simple risk stratification given by Professor Carmeli from Israel 10 years ago. That let's divide them into A, B, and C. Contact with healthcare system, either no contact, limited contact, or prolonged contact. Antibiotic treatment, no or recent, and then the patient characteristics. This, and I will cover this in my final presentation, that how we can combine all the three, risk stratification and de-escalation, in making a clinical protocol or treatment protocol. But always, whenever you decide, either patient coming from the community or patient is already in the hospital, when you decide to start an antibiotic, please take this detailed history. Last 3 months exposure to healthcare system, last 3 months exposure to antibiotics, and the patient's comorbidities. That will really help you. That will prevent two mistakes. One, giving a mice for a missile, for a mice, and second, giving a candy for a monster. Okay, we do not want a smaller antibiotic to be given in a patient of sepsis, but we do not want a big gun to be used for a simple community-acquired infection. That will be helped by risk stratification. Okay. Coming to next is de-escalation. Now, what is the overall principle of de-escalation? Initially, we give broad spectrum antibiotic, which attempts to improve outcomes and minimize resistance. But the stage 2 is, why do we start big and broad? Why? Because our cultures are not available, right? We do not know the pathogen, their sensitivity for at least 48 hours, 72 hours, if very fast, maybe 24 to 36 hours. But we do not have that much time. So we have to start an empirical therapy. Okay. But once the culture report is available, after 48, 72 hours, we need to narrow down, either reduce the spectrum, reduce the number, or reduce the duration of therapy. So that is the overall logic of de-escalation. How do we accomplish that? One is, of course, daily assessment of clinical response and some biomarkers. Sometimes in patients, fever is not a great marker. Then we have to look at the other biomarkers, CRP, routine or serial procalcitonin and other biomarkers to see if the infection is abating. Patient on empirical antibiotic and improving, stop antibiotic if the clinical assessment of patient does not support presence of infection. Microbiology cultures do not support presence of infection, and other investigations do not support presence of infection. So please always look for other causes of fever or other causes of SIRS, systemic inflammatory response syndrome. Every time, infection may not be the cause. De-escalate if your clinical assessment says that my patient is improving on day 3. If your patient is still sick, still hypotensive, it's very difficult to de-escalate. So to de-escalate, you have got a really very narrow window. What is that window? Culture positive, patient improving. If after 48 to 72 hours, patient improving, culture positive, you still do not de-escalate, then you are missing the bus. Okay. If cultures are negative, patient is improving, think about stopping antibiotics. Maybe you just need to give gram-positive antibiotic if there is a line inside center line. Or if you think the culture is negative, should I think of antifungal if my patient is still having 7 days of antibiotic use, still having a second spike of fever and all those things. Okay. And I was again repeating this. You need 3 things: culture positive, patient stable, lots of guts. Because normally ये कहते हैं कि इतनी मुश्किल से तो मेरोपेनम काम करना शुरू किया after 3 days. अब आप कह रहे हो बंद कर दो. That is in fact the time to stop or de-escalate if your patient is doing well and culture is positive. Okay. So this is the overall philosophy. Start broad to maximizing chance of delivering appropriate empirical therapy. But after that, reduce antibiotic exposure, because longer bacteria are in contact with the antibiotics, more opportunity for them to become resistant. Now it has been very clearly proven. There are so many articles now. 3 days is as good as 5 days. 5 days is as good as 7 days. Okay. So now it's shorter. It's Virender Sehwag approach. Hit early, in early, hit hard, out early. That's the approach now in critical care. Okay. So see this is a kind of one treatment protocol. If you get culture report, so green band, yellow band, red band. Green is continue treatment. Whatever you started as empirical, the pathogen commensurates to that, you can continue. Yellow band, step down, de-escalate. Maybe you started too broad, but the pathogen is smaller. Please de-escalate. And last is escalation also. Maybe you started the patient on ceftriaxone, but the culture shows it's an ESBL. You have to jack up to either a piptazo or a carbapenem. Okay. So such kind of treatment protocols, pathways these traffic light approach, green, yellow, red, in the hospital, in the doctor's duty room, nurse's duty room, can really help you as guides to modify your therapy. Okay. Coming to kinetics and okay, before I go to kinetics and dynamics, because that's a different pharmacology rich topic, let me again stop and ask if there are any questions and comments on